So welcome everyone to Fall Prevention, Be Proactive, Not Reactive with Dr. Cathy Arnold. I am Virginia with the Saskatchewan Council on Aging. I'd like to begin today by acknowledging that the land on which we gather is Treaty 6 territory, traditional territory of the First Nations, and the homeland of the Métis. And just a little bit about SCOA for those of you that may not be familiar with us. We're a community-based organization dedicated to promoting positive aging for all members of our community. And just some housekeeping details throughout the presentation. So to prevent feedback, if you could please remain muted. Dr. Arnold will provide opportunities for you to ask questions after the presentations, and you type your questions in the chat box at the bottom of your Zoom screen or at the top if you're using an iPad. And watch for a survey to pop up on your screen right after the workshop. So now I'd like to introduce Dr. Cathy Arnold. She's currently the Director of the School of Rehabilitation Science at the University of Saskatchewan. Cathy worked closely with organizations and community groups, including the Saskatchewan Health Authority, Staying on Your Feet Fall Prevention Programming, Forever in Motion, Saskatchewan Council on Aging, and Saskatoon chapter of Osteoporosis Canada. Her goal is to continue to advance initiatives to improve access and programming for older adults to optimize health and wellness. Cathy is also a member of the SCOA Board of Directors and a longstanding volunteer. So now here's Cathy.
Thanks, Virginia, for the introduction, and welcome everybody. Thanks for joining me this afternoon. I actually was thinking back to, I've done many public presentations on fall prevention during the month of November, but this is the first time that I've done it virtually. And to tell you the truth, I'm glad that we're doing it virtually today, because I think having you come and joining me in person would have been a huge fall risk today. So it's great that we're able to do this and sit in our homes and not have to venture out into the snow. So I'm going to share my screen. So just give me a moment here to get that set up. All right, so I'm hoping everybody can see my slides. So again, thanks for being here. The topic today is fall prevention, and it's certainly something that's very near and dear to me. You'll notice the subtitle is Be Proactive, Not Reactive, and that actually comes from messages that I have heard from older adults, family, and healthcare providers as part of a study that I've led for the past 3 years. And we focused on ways to determine if someone's at risk for falling, and more importantly, how do we work together to prevent fall-related injuries. So this presentation takes a little bit of a different direction than maybe other public events that I've held about fall prevention. But I think it's extremely important for me to share the stories and the messages and recommendations that come from others, because I think that's how we can learn and find creative ways to work together to prevent falls. So what I'm hoping to cover today, so I'm going to talk for about 40 minutes. I will try not to go over that so that we have time for discussion and questions. And at the end, I'm hoping that we can celebrate healthy aging. I'm going to talk a little bit about the UN Decade of Healthy Aging that has just started. Ways to identify fall risk and preventing injuries. And I'm hoping that you can apply some of the findings and recommendations from the project I'm going to talk about to your own context. And then, of course, it is Fall Prevention Month in November nationally. And I'm hoping that you will go out and share the importance of fall prevention with at least 2 other people sometime during November. And as I said, the title for this year's Fall Prevention Month is We All Have a Role to Play, which I think ties in really nicely to what I'm going to talk to you about today. So I'm going to start off by sharing some statistics, and probably none of this is new to you. In Canada, actually, there's a fairly new report that has come out from Parachute Canada, which uses Statistics Canada data. But fall injuries account for a substantial number of injury hospitalizations in Canada and also in Saskatchewan. And the most recent cost estimate of falls from 2018 data is that approximately 10.3 billion will be spent annually for injury hospitalizations related to falls. And that's falls across all age groups. And I'm going to emphasize this a fair bit today because falling is not just a risk for injury in older adults, but it is the highest cause of injury in older adults. So who's at risk? Well, actually everyone is. And as I said, across all age groups, it is the highest hospitalization for injury, except for one age group, and that's the ages of 15 to 24 years, where actually transportation incidents are the highest cause for injury hospitalization. But if you look at across all other age groups, the highest cause for injury hospitalization is related to falls. The reason falls are a greater concern for older adults is that the injuries tend to be more serious and often result in hospitalization. And we've noticed that this statistic is increasing as well. So in Canada, older adult fall injury hospitalizations increased by 9% in a 3-year time span. And that's expected to continue to rise. So just bear with me for a minute, because I kind of wanted to do a little bit of a comparison. So I did say falls are an injury risk across age groups, and the two age groups where it is the highest injury risk are in children 0 to 10 years, and then adults over the age of 65. So I wanted to just compare a little bit of the stats across those two age groups. So for children 0 to 10, falls are the leading cause of about 45% injury hospitalization. Falls happen regularly for kids, daily, if not hourly, in the younger age groups, and is really part of natural growth and development. More commonly in males, 58%. And the more common falls for kids are from one level to another. So typically with jumping from a height, going downstairs, those kinds of injuries are more common from falls. Leading cause of brain injury for kids, though. And if you want to know what happened during COVID, and I just caution the stats here a little bit because some data is lacking across all provinces, and Saskatchewan is one province where we just don't know exactly the data during COVID. But there was a decrease, particularly for kids, with 21% less hospitalizations in 2019 compared to 2020, and that's for under 19 years of age. So if we look at the older adult age group, age 65 plus, falls are the leading cause of injury hospitalizations again, but at even higher rates. So 77% up to 85% of all injury hospitalizations are related to falls. More common in women, and most common falls happen during walking, and not stairs and not on ice. So most commonly falls are going to happen just walking on regular surface, typically in your own home. So those are the most common falls for older adults. Also the leading cause of brain injury in older adults. And if you want to know what happened during COVID, not the same result as for kids. So there was a little bit of less hospitalizations during COVID. 2019 or 2020 compared to 2019 at 2% less. So bear with me for a minute because I want to talk a bit about the UN Decade of Healthy Aging. And if you haven't heard about this, I'm hoping that you'll remember that this is the decade coming up. It was actually supposed to launch in 2020, but because of COVID, they delayed it for a year. This is worldwide. The launch of the Decade of Healthy Aging. And what I wanted to do is just describe briefly to you the 4 calls for action related to this decade, because I'm going to loop back to that as it relates to some of the messages that I want to share related to fall prevention. So the 4 calls for action are age-friendly environments, combating ageism, integrated care, and long-term care. So age-friendly communities or age-friendly environments, you may think of physical kinds of environments and things that would make it more age-friendly, but age-friendly is a very all-encompassing term, and it refers to physical, social, and economic environments. And it means removing barriers and implementing policies, systems, services, technologies to address the social determinants of healthy aging. So it's all encompassing and quite big. Combating ageism, and you're probably familiar with that, the stereotyping, prejudice, and discrimination based on age, which affects everyone, but can result in negative effects on health and well-being of older adults. Integrated care refers to non-discriminatory access to good quality essential health services, including, and I emphasize, prevention, promotion, curative, rehabilitative, end of life that is safe, affordable, and effective. And last but not least, long-term care, access to good quality long-term care to maintain function, enjoy basic human rights, and live with dignity. So those are the 4 calls to action. And as I said, I'll loop back to those later. So what I want to share to you today is some results and recommendations and messages that has come out of a project that is quite a large team. And we have 12 members on our team. And we also have 3 community members, older adults who are our patient family partners. And the focus of the project, the grant was actually called a collaborative approach to comprehensive screening and assessment of fall risk for older adults across the continuum of care. And I've labeled it as Project Proactive because, as I said, that's one of the key messages that has come out of this project. The objectives of the project was to investigate what's happening right now with healthcare practices and experiences of who is at risk of falls, how are they assessed, and how is that being followed up in Saskatchewan, and what are we doing to prevent the next fall? And ultimately, we wanted to develop a consensus of recommendations. And as I said, I think it falls in very nicely to the title of Fall Prevention Month, that we all have a role to play. So there were 4 phases to the project, and I'm going to spend most of the time talking about messages we heard from the focus groups, but I will go through some of the results we found in the other phases. So the first phase is something we called a scoping review, and that really was just looking at all the evidence and the research, but also things that are posted on websites or organizations use around fall risk screening, and we did that internationally. The second phase was a survey that we did of healthcare providers in Saskatchewan. The third phase was focus groups that we ran for older adults, family caregivers, and healthcare providers in Saskatchewan. And then the final phase, which we're in right now, is trying to share the knowledge we gained and build some consensus to move forward so that we can take the next steps in fall prevention. So I'm going to just go through each of the phases. So there's not much I'm going to go through with the scoping review. It's actually published in the Canadian Journal of Aging. And basically what we found was that there were 22 clinical practice guidelines that healthcare providers can use that are evidence-based, that would help them to know how to identify fall risk and make decisions to plan prevention. And boiling that down, basically things that help to identify who's at risk is if you've had a fall in the past year, so if you've had prior falls, if you have walking or balance challenges. So those are the 3 sort of main things that are common to all of those guidelines. What we did find is that all of those guidelines also suggested there needs to be ongoing support on how do we implement those guidelines and sustain that. So I'm going to just go through a couple things about fall risk, and fall risk is complicated. I guess that's the main thing that I want to share with you. There's actually been over 400 risk factors identified, which is why just about everybody's at some level of risk for falling. And it's cumulative.
Yes, Get it.
Just told me that you couldn't get the sound on
I'm going.
your course.
Oh,
And I just fixed the problem.
Okay.
okay, I think we're off. So there's over 400 risk factors identified and they're cumulative. So the more risks you have, the higher risk that you have. Some of the more common ones, the main ones are our age. So as you grow older, you're at higher risk. Balance, walking ability, muscle strength, cognitive status, fear of falling, which means the higher fear you have fear of falling, the more at risk you are, which may be counterintuitive. You may think that that makes you more cautious, but that's not the case. And then polypharmacy or on being on multiple medications. So this is a bit of a busy slide, but it's important because this is one of the key recommendations. This is for healthcare providers of what they should be doing to identify people who are at risk of falls. And this is widely shared in Canada. It comes from the Registered Nurses Association. It's a fairly strong evidence-based guideline. I know that they use it in Saskatchewan within the Saskatchewan Health Authority. So it's out there and people know about it. And I think it's important that you know about it because then you understand as well what people should be doing to assess your risk. So first of all adults, regardless of age, should be identified for risk. And as part of any admission to hospital, emergency room, after any change in health status, and at least annually. So every year, somebody should be asking you, have you had a fall in the past year? So identifying that history. And do you have any walking, balance, or mobility difficulties? And they should be doing both, asking you that question and watching and observing how you walk and how you balance. So using some form of clinical judgment. So that's the basic screening. And then if someone is at risk, then they should have a more comprehensive assessment to identify, well, what are the main factors that put you at risk? And what would be the interventions for that? And using some kind of tool to help make those decisions. And then referring you to, if you've had recurrent falls, if you have multiple risk or more complex needs, to the appropriate person or team to intervene. So those are the practice recommendations. So boiling that down from what we found out from our review, and my research team even said to me, we probably could have just skipped that step because we all know that there's guidelines out there. So there's knowledge of what to do, what's helping us and what's hindering us from doing it. And that's, I think, the complicated question and what we wanted to try and understand better. And remember that it's all our role to play. So the second phase of our study was a healthcare provider survey. And we did this through professional organizations in Saskatchewan. So it's quite broad. We had nurses, physical therapists, occupational therapists, social workers, kinesiologists, pharmacists, physicians. And we had 323 respondents. Most were in urban centers, but we did have about 40% in rural. And we had fairly equal distribution of healthcare providers working in hospitals, long-term care, and community. Most were nurses and most were women. What we found out, and I'm not going to share all the results from here, there was quite a bit that we had in the survey, but we found that there were 63% who reported that they had received any kind of training for fall risk assessment, which means there's about another 37% who said they did not, which was a bit surprising to us. And most were not familiar with the clinical practice guidelines. We did have, fairly good range of ages, and actually 30% had graduated from their professional program less than 10 years ago. So I'm just going to share a few things with you. And we had a series of statements that they could respond yes or no to. And then we did some comparisons of where they worked, rural or urban, if they worked in long-term care or community or acute care. And in this slide, it just shows some of these statements and some of the differences that we found depending on their practice setting. So respondents all agreed there's strong evidence to support fall risk screening assessment for older adults. We did find that those who worked in long-term care felt stronger about that statement than those who worked in community and acute care. We also asked questions in terms of support that they had from their organization or their professional peers and resources. And what we did find was that healthcare providers in long-term care were more likely to agree that they had access, support, and perceived standard from their peers in their organization versus respondents working in acute care and community care. We didn't have enough people in every profession to compare professions, but we did look at comparing nurses to other clinicians that we had in our sample. And everybody agreed that there's strong evidence to support fall risk screening assessments, so there was no difference there. But there were significant differences, and nurses were more likely to report access, resources to intervene, and a culture of support and standard from their peers as compared to other clinicians. And then I just want to bring your attention to this one. These were challenges that felt there were some barriers to conducting fall risk screening and assessment. And time constraints certainly was one, more so in long-term care and in hospital setting. And extent of documentation is another one that was more reported in community acute care. But it's this last one here that I wanted you just to be aware of, in that everyone from all of the settings, over 60%, indicated they felt that clients who were reluctant to disclose they had fallen or that they were concerned about falling was a barrier that healthcare providers felt existed in being able to identify someone at risk and intervene. So in summary from the survey, healthcare providers agree there's strong evidence to support fall risk assessment, but they're not familiar with the clinical practice guidelines. About 2/3 report they received training, and we also found if training was received, they're more confident to do it. Nurses are more likely to report support and access to resources, and healthcare providers in community are less likely to report that. And that healthcare providers report that clients, patients are not disclosing information about falls, and this is seen as a barrier to implement prevention measures. So the next phase that I wanted to just share with you was the focus groups we had with older adults, family caregivers who had experienced an injurious fall where they actually had to seek care, and then healthcare providers who provide care to older adults. And we had 29 older adults and family caregivers, and we actually had more in rural sites, 58%, and we had 12 healthcare providers who participated. And we asked the questions about the story of their fall, their perceived risk, healthcare received, transitions after the fall, and what they felt about future fall prevention and the messages. So the experience of falls that we heard ranged from minor scrapes or bruises to actual death. And it was hard as a facilitator for me to hear those stories. They could be very upsetting at times. And they were certainly upsetting to the older adults who were telling their stories and the other members of the focus group. But I think that those stories are really helpful for us to understand a bit more about how can we prevent falls. So I'm going to share one of the stories. It's not all that this person described to us. I fell, I was baking, and I climbed on a stool to get something very high, and then I stretched for it. Like I got dizzy and off balance. I fell on the floor and was unconscious. I hit my head on the island. There was an island and a garbage bin, so I was unconscious on the floor until my daughter came home. Then they called the ambulance and I went to the hospital. I had 4 broken ribs and my shoulder is fractured. My head had a severe hit, but there was nothing with the head. After that, I spent about 15 days in the hospital, and then I went home, and I never fell again, but I'm always off balance. So once we got through all of the information from the focus groups that we heard, our team spent time to analyze all that we heard, and we developed some themes. And what we came up with was an overarching title called Be Proactive Rather Than Reactive, and that transcended across all of the themes. And then there were three main themes: independence, denial, and self-blame. And there were three sub-themes related to that: it won't happen to me, I'm okay, and reactive, not proactive. And then a second main theme of impacts of transitions, short-term and long-term, and some sub-themes. It's confusing and so exhausting too. It falls on the family if you have a family. And then the third main theme: ways to improve care, access to resources, a multifaceted approach, and communication is an important way we could improve fall prevention efforts. So what I'm going to do is I'm going to go through each of the sub-themes and just share with you a few quotes and thoughts on some of the messages that we heard. So first one is independence, denial, and self-blame, and the sub-theme, it won't happen to me. And we heard this a lot: it won't happen to me, but when it did, I'm to blame. We heard a fair bit of negative descriptions from older adults who had fallen, that they felt humiliated, embarrassed, stupid, dumb, clumsy, surprised. I didn't see it coming. And I know risks, I'm careful, I was just rushing. We also heard healthcare providers telling us same messages that they heard from the clients' patients. They saw things like, I can do it on my own, and I didn't want to bother you or ask for help. Oh, sorry. Go back. So one of the quotes, just to summarize that: I thought I knew enough about falls not to fall, and yet I did everything that I shouldn't when I did fall. I didn't think it would happen to me. The second sub-theme that is similar but a little bit different is titled I'm okay. And again, we heard quite a number of stories of ignoring fairly serious injuries and waiting or not going to seek care by older adults. Family caregivers and healthcare providers also mentioned these stories, and they really had to do some prompting to try and encourage people to seek care. One of the quotes that emphasizes that: I felt embarrassed. I just thought, oh, I hope no one's seen me, but I think I got up right away. I wasn't sure, but I did not feel good. And then the third sub-theme, the reactive, not proactive. And as I said, that was cross-cutting across all of the themes, but we felt it fit the best in this one. And we heard from older adults and family caregivers that the prevention advice given was either not there or not particularly helpful. So things we heard from older adults that they heard from healthcare contact was: be more careful, slow down, don't fall. And what they really wanted to hear was more information and specific actions about what they should do to prevent the next fall. Healthcare providers also indicated that they felt they should be more proactive and that they were being more reactive. And this theme again was consistent throughout. So some quotes to support that. I think when I went to the emergency, the nurse and the doctor, they do the tests and they come in and they tell me the results, but they never really go into prevention or that kind of thing. I just think whenever anything's always reactive rather than proactive, something has to happen first before anything's done. But that's just life, if you ask me. That's just everything. Being in primary health care, we should be more proactive, and we're reactive. It's the phone call, they've fallen, right? And we're not doing it, going in and assessing risk. So the next main theme was the impact of transitions. And again, we heard this across all focus groups, both short-term and long-term transitions. And transitions could be small, which could be room transfers that might happen in the hospital or different people providing care, or larger kinds of transitions, such as moving from community into long-term care or hospital back to community. But all those transitions, we heard words such as it was disorienting, confusing. For some, it prompted triggers of previous trauma experiences. And family caregivers and healthcare providers said they noticed really fast deterioration of function and deconditioning. What many felt was missing in those transitions was explanations about why the transition was occurring, how it was occurring. And again, that loss of cultural and personal needs support, such as ceremony or environment. Healthcare providers also said transitions were challenging for them too, in a little bit different ways. Communicating to other staff, finding time to do rounds, the transition huddles that might happen, not always feasible for everybody to be there. So they also struggled with transitions. So some quotes to support that. Not being able to sleep, so getting up and being confused. He always hated us to leave. He felt so alone. He said so many times, I'm frightened, I'm afraid. I needed to get up and smudge and pray during the day or before bedtime. I do a lot of that. So I don't know how you get a hold of them. I wanted to smudge, but nobody was around. So those things that are important to people who are not there. The second sub-theme was it falls on the family if you have a family. And we heard this from caregivers for sure, as well as older adults. They felt they really needed information, a family meeting, particularly transitions back home. And we have heard that even more so in the rural setting. There was also lots of positives said about the care received by professionals, but they also felt they were living with the fear of the next fall and changes to routine. Healthcare providers also stressed the importance of communication with the family, but wasn't always easy to find the time, and they felt there were challenges, and we heard that from frontline staff. So those were some of the words that we heard. I think in a lot of situations, when someone goes into the hospital and they get discharged, there isn't any real advice. You're going home, maybe they expect your family or your husband or someone to look after that person. But if they're by themselves, I don't think they really give you any advice or follow-up. And this next quote was from someone in a rural site, and it actually was a question around equipment. And the response was a friend that came and started harvesting with us and said, so I'm going to put up one of those in here right now. And he did that very well. And it actually was something in the tub as a bar to get things set up for ease of mobility. The next sub-theme was access to resources. And this sub-theme, we actually heard some differences in rural versus urban experience. So the urban experience, there was more messaging around, they weren't aware of resources available, but they actually were available. And from the rural experience, we heard that resources were not available. And things that came out was the need to travel to larger sites to get care, equipment reliant on family to find, get, and fix, lack of local prevention and exercise groups, and difficulty getting home care. Healthcare providers also noted importance in home visits for prevention and follow-up, and trying to increase access and information about programming in the community. There were lots of recommendations of things we should do, and it ranged everywhere from handing out brochures to having set up a fall phone line that people could call in, video presentations, and it was also mentioned computers are not always accessible for everybody. So I wanted to share this first quote. I've blocked out the location just to maintain privacy, but this was a story of someone who had a fracture. So I went to rural hospital and they got me ready to take me by ambulance to the urban hospital, and I had to wait. I was there a week because I had to get my elbow prepared. And after that, they decided they got the thing on it. I got back to the rural hospital. Then the ambulance sent me back to the urban hospital. I had to pay for that one, but I don't think I could have sat in a car because I wasn't supposed to put my feet down on the ground yet. I stayed there I was in the hospital, counting both hospitals, for about a month. And from a healthcare, from a community member, well, I don't know that people know where to go. That's kind of the common theme. I'm always amazed when I go into someone's home on a home visit that they don't even know about CPAS, which is Client Patient Access Services, and they're desperate for help. So to me, a lot of it is about sort of knowledge of how to find the resources and where they're available. And the second sub-theme, ways to improve care, it's a multifaceted approach. Recommendations for change were wide-ranging, from more community-based prevention strategies. It was mentioned education for school-age children, having some kind of a provincial strategy or more full-time coordinator positions in healthcare, and more impactful messaging. Someone said to us that fall prevention messaging should be more sexy. More consultation with family and support for transitions. And healthcare providers and older adults all emphasize the importance of a team approach and communication. So a quote to support it would be wonderful if there were community-based exercise programs or information sessions, coffee and a video, how to prevent falls, how to fall-proof your house, or the social interactions that also have an education portion. Get lots of people to come if there's a social aspect as well. And the final sub-theme is communication. Is an important way we can improve. Again, transitions here and finding the time to communicate, importance of in-home, team approaches, a central way of communicating, and having a fall plan in place. So final quotes, communication, something that I have marked down as a barrier to ensuring fall prevention is doing because it's hard. We all document in different areas. And how does that information get transferred to primary health where they need it to maintain safety at home? How does it when we don't have the time, and OT doesn't have the time, or PT doesn't have the time to sit and have those conversations? Because it's not built into our day, it's not built into expectations for practice, it's not built into our culture for safety for the patient. How do we sit and have those conversations? So boiling it down in what we want to share, and I'm going to have Virginia send out this to you after this presentation. I actually shared it with SCOA a while ago, but we developed some recommendations, and on the left-hand side was key messages for everybody out there about fall prevention and what we learned from the study. And then we also developed recommendations for healthcare providers. So I'm not going to go through that. But what I wanted to emphasize was some of the key messages and how I think it relates to you, and hopefully, what you can take home today. So the first message was about using an evidence-based approach. And I know that that's messaging for healthcare providers, but I think it's messaging to everybody to first tell your healthcare provider about falls, risks, and fears. Don't hold back information because they need that information to help make decisions. Asking about falls and checking about changes to balance and mobility should be routine. So when you see someone for an annual checkup or you go to see your physical therapist, even if it's about something else, they should be asking you, and they should be asking questions about balance and mobility. So be your own advocate. And I put in there demand feeds supply, because I think if we can advocate, then it's going to prompt healthcare providers, oh, I guess that maybe I should be including that more often in my assessment. The third message from that list of 8 revolves around training and education. And again, certainly for healthcare providers, we need to do a better job there. But I think for everybody, it's really important to keep learning, know what your risks are and when you might be more vulnerable to risk. So for example, for me, I know because of some visual changes that I have, that I struggle at night. I don't see things as well. I don't see steps as well. I may not see a slippery, icy spot. So I have to be extra careful at those times. It's also important to think about a fall plan. So do you have an idea what to do if you did fall and you didn't have somebody with you to potentially help you? And I'll share with you, I mean, there's some programs and ways you can learn how to get up from a fall, and that's a really important one. If you can, do you have some method of contacting somebody? And there's certainly different alarm systems that are available. Be aware of programs, resources, and get involved. Stay physically, mentally, socially active. And then messages 5 and 6 revolve around rural needs, but also community. And I just am using an example here as an organization, something that developed in a very creative way from the city of Saskatoon and Saskatoon Fire Department called Remembering When. And they have a fire and fall prevention program for older adults, and you've probably heard about it. But I think that's a great way of something that really evolved out of a community need, and organizations work together to provide that program. And certainly Council on Aging has been an incredible support for fall prevention and messaging and opportunities to share as well. So quick recap, take home messages. Start the UN Decade of Healthy Aging in Saskatchewan, Canada, with a focus on proactive strategies. And as I said, I think the results of this project speaks to those 4 calls to action, that we need to break down some of the barriers for access to services that support age-friendly and aging in place, and probably particularly in rural and remote Saskatchewan. We need to call out against ageism by avoiding unhelpful and derogatory words like slow down, you're just getting older, or it's to be expected. Those are not helpful. We need to continue to grow integrated care with improved methods of communication, particularly across transitions, including prevention and promotion. And we need to support good quality long-term care to maintain function and live with dignity. That includes risk. So we know what to do to prevent falls and injuries. It's figuring out how to do it together. We need to be aware that everyone's at risk, to look for signs, use resources, and communicate with each other, and share and advocate with the community. So I just acknowledge my team and also the collaborators and supporters, as well as the funding support that I have through the Saskatchewan Centre for Patient-Oriented Research and Saskatchewan Health Research Foundation. And I will just leave these resources. You can certainly go back to them when the slides are available after the presentation. So I'm going to stop there, and I will stop sharing my screen and open it up for questions.
Thanks so much, Cathy. You can type in your questions in your chat box at the bottom of your screen. This presentation will be available on our website as well, on our YouTube channel. I will be sending out a handout from Cathy to everyone that's registered for the session. So I will do that probably later today or first thing tomorrow.
Marie, I noticed your question. Is it possible to have a community physio come to a building to have a falls prevention session? Yes, it is. I would recommend community therapies. There's someone who does the Staying on Your Feet program as well. There is a fall prevention coordinator within the Saskatchewan Health Authority. Unfortunately, right now, both of those individuals are redeployed because of COVID-19. So I'm not sure they'd be available right now, but they should be able to help out with finding some resources there for you once they're back. Did people say why they are reluctant to tell healthcare providers about their falls? That's a really good question. And I think it's probably complicated and likely quite personal. I think that probably, Elliot, it goes back to one of the first themes where people felt embarrassed, humiliated. They didn't want sometimes family members to know because they thought maybe that would show they didn't have enough independence to live on their own anymore. So I think there were some complex reasons behind it. And I don't know. I think that's a really good question that probably needs to be explored in more depth. Okay, Jane, can you talk about how much exercise is required for maximizing all of us staying on our feet and not falling? Okay, so the latest recommendations are that you should be doing about 3 hours per week of exercise that challenges your balance to some extent. So you should be doing something that challenges balance, and that's optimal. And so I know lots of people say, wow, that's a lot, 3 hours per week. But I just did an interview with someone who's doing a blog on healthcare research right now. And she was asking that as well. And my response was that, 3 hours a week is also like a half hour, 6 days a week, and it can be simple things. So it can be, standing doing your dishes and you spend a few minutes just shifting your weight and balancing. Walking is balance. Any kind of movement or transitioning, going up from sitting to standing is a balance type of challenge. So I think just trying to stay mobile, and if you're not the kind of person who can focus on exercise or go to a program for an hour at a time, that you still can get those benefits just doing it in short spurts. And I actually was just reading an article in the Star Phoenix of some new research around exercise that talks about exercise snacks, and thinking of exercise as taking just a short snack to do a few minutes of exercise, and that can be as beneficial as spending time at the gym. So I think that's the good news for those of us like myself that struggle sometimes to spend a good chunk of time. So I hope that answers your question. Is the reason the percentage of women that fall is that more women walk and exercise than men? I don't think so. And actually, it's a bit of a conflict. The gender differences are a bit complicated because in certain age brackets, men actually do fall more. So when you get into the older years getting to 90 years and older, men tend to fall more than women. Some injuries are equally common in men as women, such as head injuries. Women tend to break their arms more and break their hips more, and that might be partially due to some of the bone changes that occur. And why women might, it's not necessarily true that women fall more, but women go to the hospital more for injuries. So it's more an injury thing. And one of the reasons that they sometimes might fall more might be due to some muscle strength kinds of differences as well, but I don't think that's necessarily true. So it's more the injury hospitalizations, and the injuries are more common in women than men. Physios Brad and Dave on YouTube. I don't know though the YouTube videos. Doing exercise to strengthen and increase balance. Thought it was excellent. Okay, well, a good suggestion. I haven't checked that out. I would also recommend, and I think I saw Howard and June Giles in on this as well, is Forever in Motion, and has exercises, and they have virtual sessions going on right now, and a very excellent program and focuses on balance kinds of and strengthening exercises. Forever in motion, yes. I'm not sure I can answer that question. So a question from Cathy, is it true if someone falls and calls 911 and it's only a fall, firefighters will be sent out free of charge to pick the person up? Is this true? I honestly don't know I can answer that question with accuracy. I'm not sure the process. I do know firefighters do go in, but I'm not sure the protocol that happens there. From Deb and Dwight Edmondson, there's something about NeuroSask. I think that is that an exercise program? I don't know if one of you wants to elaborate.
This is Deb speaking here, because I was just typing a message in to you. But NeuroSask has classes on Tuesdays and Thursdays at 2 o'clock, and they do exercising, and then sometimes they have a guest speaker also.
Great. And can anybody participate in those?
Yeah, I was just going to send you the email if you want to have that in this presentation.
Sure, that'd be great. Virginia, if you want to add in that email with what's sent around after, that would be great.
Okay,
Sure.
yeah.
Yeah.
Did it come across? Sorry, I will mute off here, but did the email come across?
Yes, it did.
Okay, good.
Yes.
Okay, thank you.
Yeah, great, thanks.
Okay.
Yeah. And from Jane, what have you found about the impact of footwear on falls? Well, footwear, yes, it certainly is a contributor to falls. I don't know if I can comment on how much of a contributor, but we do know in some fall situations, it does certainly impact, if not cause, the fall. And some of the footwear issues are indoors, would be floppy slippers that tend to slip off your feet or you trip on easily. And outdoors would tend to be shoes that just don't have good grips. So those are probably the two main footwear issues that tends to happen.
Any more questions for Cathy? If there isn't any more questions coming in, I don't see any, but I'd like to thank everyone so much. Before I forget, thanks so much for Cathy for doing this presentation, first of all, and thanks everyone for attending our presentation, and check out our website, scoa.ca, for all our upcoming events and programs, and watch for the survey to pop up after the meeting ends. So thanks again, everyone, and thank you to Cathy.
Great. Thanks, everybody, for joining me and having some great questions. I noticed Howard and Giles also put in a contact for the Forever in Motion class, Virginia. So if you want to add that as well, and then people have
Sure.
that
Yes,
email.
I'll go through all these messages too.
Okay. All right. Well, thank you, everybody, for listening, and have a good rest of your afternoon.
Thanks, everybody. Bye now.